screening program that they have in the country. Now, the reasons they quote this that they are not making a difference in reducing the morbidity or the mortality with regards to prostate cancer. We have a lot of trials on PLCO, the GODSPEC prostate cancer screening trial. Now, what would be the advice probably you will give it in an Indian setup? Dr. Kadiresan, will you like to take this question? When would you do it? At what age, sir?
Yeah, as far as as far as prostate is concerned, most of the times what we follow is all the Western guidelines, either European or the American guidelines. See, there they detect prostate cancers at a very early stage, and almost more than 90% of, close to 90% of the prostate cancers are detected early. And there they almost everyone will have PSA some way or other during their career, and that could be one reason why PSA as a screening modality may not improve the survival there. But in our country, we don't have any trial to say that PSA screening is useful, not useful. We don't have anything right now. And when we see in our population, almost 50 to 60% of them are even more are presenting in the metastatic state. So in our setting, I think PSA screening will make a difference, but we are yet to reach that level of not doing PSA screening. That's what my idea is.
So this is what the Canadian Cancer Task Force recommendation was. Less than 55 years, they don't recommend screening. 55 to 69, that is where the most European centers will recommend screening. Even there, they are saying that the recommendation is not there. And more than 70, of course, the quality of evidence is so less that they don't recommend at all. So in conclusion, what do we say? This is what I follow. I'm not saying this is what we recommend in India because we don't have such a guideline. What we follow is the European guidelines, the European Association of Urology guidelines. So start screening only when a patient is more than 50 years. And if a patient decides to be screened and is aware of the risk and benefits of screening, then only do it. Offer PSA and digital examination every second year from the age 50, starting from the age 55 to 69, and stop it when the mean age is 70, more than 70. So this is the European Association guidelines. And we get a lot of these papers on radical prostatectomy and margin positivities. Now I was going through a lot of series that they have. They are even getting some randomized control trials evidence to say that close margins or even a small microscopic positive margins in prostate cancers with either with robotic prostatectomy or with open retropubic, they don't seem to make a difference with regards to survival. Your opinion? Do you have any radiotherapist here on the panel? Sir, yes, please. Sir.
Margin positivity, yes, there are various studies to say that it doesn't dictate the long-term outcome. But you have to also take the other factors into consideration, like high Gleason score grade and whether lymph node positivity and things like that. So there is, then the question comes, when will you give radiation? Whether you will give it straight away or will you wait and watch? So different theories are well established. Different schools of thoughts are established. Previously, there was a tendency to wait and watch because not all margin positivity turns to progression. But nowadays, there is with frequent PSA monitoring. When I finished the training about 20 years back, the cutoff was around 0.6. Then it became 0.5, then 0.4. Now they say 0.2. Early salvage is the best. So that's the take-home message, I would say. So we could still wait and watch. Now, with high-risk patients, they are saying multimodality treatment has come into place, like with surgery followed by close radiation, not waiting and watching. Multimodality approach. Again, that's for the younger, fitter lots. The other patient can go straight for radiation, hormones and radiation.
This sort of a high-risk population that you're talking about, where they get radiation after surgery, compare them with only a radical radiation. Is there a difference at all? Are the surgeons really pushing you? What would you say?
Unfortunately, there is no evidence, and I don't think there will be
there will never be an evidence in this. I
high-risk prostate cancer patients. So we have to strike a good balance because prostate cancer is easily treatable and potentially curable for a very long time at least.